have, I do believe a stereotype in my mind, but I'd like us to take a quick break, and when we come back, I'd like us just to go back to the basic, and for those who are viewing and listening, what is a stroke? How do we recognize the sounds, the symptoms and the signs of it? And also, I've been hearing about this FAST, the letters FAST, and I'd like you to explain that to us when we come back.
Sure.
Thank you. This is Your Health, Your Action. Tonight we're taking a look at strokes and stroke recovery. Remember, you can participate. You can call us on 228-5562 or 228-5563, or you can WhatsApp your question or your comment on 228-5562. Tonight we have with us Dr. Harley Mosley, co-director of the stroke unit at the QEH. And the questions before the break: what is a stroke? How does one recognize the symptoms? And when you hear of strokes, you also hear of the word FAST, and the letters stand for something. So, Dr. Mosley?
Thank you very much, Peter. Well, once again, to reiterate, when we're dealing with time, we're dealing with brain tissue. And when we're dealing with brain tissue, we want to think fast, okay? So what is a stroke? Let's answer the first part. Well, essentially, the brain has a blood supply, and the blood supply takes nutrients and oxygen to the brain tissue. When this supply gets disrupted by either a clot or a rupture of the blood vessel that is taking the nutrients and the oxygen, the brain tissue no longer is receiving nutrients and the oxygen, and the tissue starts to die. And that is what we will call, or is known as a stroke. Once this occurs, because of the nature of the brain and the fact that the brain controls all of the functions in the body, either directly or indirectly, you can get what we call signs. They may either be focal, where they may be focused on, may be limited to one limb or half of the body, depending on the size of the stroke, or they may be what we call global, where the entire brain is affected by the massiveness or the size of the lesion, and these present as either a coma, sometimes confusion, or unfortunately death, which leads us again to reiterate time and fast, because strokes kill. I know in the past Barbadians have referred to them as Passovers, but strokes kill. That is the first thing that you need to understand. Now, how do I recognize the signs of a stroke? And this is where that FAST acronym comes in. All right, we took the most common sign, such as F for face. If you suspect somebody has a stroke or is undergoing an event that you think may require you to question whether or not they're being affected. The F is for face. So you ask them to smile for you. If they can't smile on both sides of their face, or it's a lopsided smile, or even if they smile and they know that there's numbness on that side of the face, that is the F. Okay? And that's the first suspicion. Then the A. A stands for arms. You ask them to raise both arms. If they can raise both arms and one feels weak, or more dramatically, if they're only able to raise one arm, or if they raise the arm and they complain again that one arm feels numb or funny versus the other one, then again, that's another sign of a stroke. So that is FA. Then the S. You give the patient something, or the person you're concerned about, something simple to say, like the sky is blue. Ask them to repeat. If they can repeat the sentence clearly, then that is okay. But if they sound confused, or they're unable to repeat the sentence, or they're just doing their own thing and just speaking in some sort of unintelligible or unrecognizable speech, then that is the S. So FAS, and the T is, by the time you've noticed FAS, T is time to get help. So time to get help, because time is brain tissue. So either you call the ambulance in our jurisdiction, or if you can't call the ambulance and or define that the ambulance is taking a little too long, because believe me, the ambulance service has been very busy nowadays, then if the person can get into private transport, you try to get them to the emergency room as quickly as possible. I spoke to my colleagues recently about this, and they tell me the ideal time to get a loved one or a relative or just a friend or even a neighbor that you are suspecting has a stroke to the emergency room, they would like you to get there within a 3 hour time period. There's a reason why.
3 hours.
What's that reason?
What's the reason?
Yes, 3 hours from the onset of the stroke, and this can be taken from when you first recognize the stroke signs. However, one case, if the person has been awoken by and you've noticed the FAS, you then have to take in consideration the time from the sleep. So hopefully they've only slept less than 3 hours. But the reason why you want a 3 hour time period is that in the accident and emergency department here, we're prepped and ready to instill what we would have a clot thinner, and where we can inject the clot thinner into your bloodstream if the stroke is caused by a clot, and you can actually resupply that brain tissue. So because time is important with the resupply of the brain tissue, you can actually save and maybe even reverse some of the neurological or the impairments or of the person that you've taken to the accident emergency department. However, if you fall outside that 3 hours, it's very much left to the doctor's discretion. And even then, sometimes because of you've taken too long, you do not fit the criteria to get this clot thinning agent, or thrombolysis is what we call it.
Dr. Mosley, we know full well that prevention is better than cure. Let's link this now to the whole concern about non-communicable diseases. What causes this? What causes strokes, and how best can we work to prevent it?
That is a very, very good question. And this is one where I think for a long time we as doctors have taken the lead role in it, but I think it's time for us to actually incorporate the patient and their families in this as well. Strokes are influenced by factors that we can alter and factors we can't alter. We call them non-modifiable, where we can't change it, and we call them modifiable, where we we can change it. The non-modifiable factors, which we should all know of, the first one is age. Age greater than 55 years of age, um, that increases the risk of stroke in both male and female equally. And with each additional decade, the risk doubles. Okay? The second thing is gender. Males are more susceptible to strokes than females. The third thing, which I don't, which the international medical literature has shown, but in the West Indies, I find we have a small problem because it's a little hard to delineate. But nonetheless, the international literature has shown that blacks are twice as likely or at a higher risk of getting strokes than whites. And I say that in the West Indies because sometimes we're all mixed up, for want of a better term. Then, of course, there are other factors that you cannot change. If you had a past medical history or a stroke in the past, that has happened, and you're at an increased risk of developing another one. And the other one, of course, is if your family should have any history of a stroke. Now, the reason I say that patients need to take this into consideration is that once you know that your these are your risk factors, then you can start doing things with risk factors that you can change or modify. And the modifiable ones are, it's a significantly longer list, but the important thing about them is that they are preventable once they are treated aggressively. The number one cause, which leads to almost 7 times the risk of, of, of persons developing a stroke compared to persons in the similar age group, is hypertension. And in our society, hypertension, as you know, is a non-communicable disease, and we're having issues with patients remaining compliant on their medication. Because if you can keep their if you can keep their blood pressure within a controllable target, which the doctor has set, and they take their medication daily, then this now becomes a non-issue. However, unfortunately, bad habits have crept in, and patients who are hypertensive often take the medication when the pressure is high, and when the pressure isn't high, they don't take it. That is not how it is designed to be taken. If you are, unless your doctor has told you specifically to stop taking the medication, you are to continue taking that medication and be seen on regular visits. The other the other modifiable factor, which we're talking about non-communicable diseases, but is nowhere as high a risk factor as hypertension, is diabetes. Diabetes is a diabetic has a 4 times more likely risk of developing a stroke than a non-diabetic. However, in our case, there are a lot of our population who are both diabetic and hypertensive. And if my math serves me correctly, if you're 7 times more likely with hypertension and 4 times more likely with diabetes, then you multiply the figures out. So you are 28 more times likely to develop a stroke with hypertension and diabetes. So it's all the more that you should try your level best to be compliant and visit your doctor. The
Dr.
other
Mosley?
things that
Just let me interrupt you here.
Sure.
We need to take a quick break. But when we come back, I really and truthfully want to understand what the medication for, hypertension does
To your body to assist you with the hypertension. I don't think that people really understand what it does and why it's important to take it. So we're going to deal with that when we come back. Welcome back. Remember, you can participate. You can call us on 228-5562 or 63. One of the memories that I have of my family is an aunt who always said that it was when she'd felt well that her pressure was high. I've never understood it, but it was something she always said. But then the medical fraternity also says it's a silent killer. So what is the importance of taking A, the medication to time, and B, what does that medication do?
Oh boy. Well, I must, first of all, as being a physician, this is not my full area. There are internists around there that would answer, but I will tell you that essentially there are different classes of medication, and different classes of medication act in the body differently with regards to hypertensive medication. And some are more likely to cause side effects depending on the patient than others. But the problem is that a lot of people have this bad habit of when the pressure is good, they stop taking the medication. If you feel you must stop taking the medication, you must go to your physician and ask a question. And a case in point, a lot of those medications, for example, and that's a very good question, have an interesting side effect. For example, with men, some of those antihypertensive medications can cause impotence. Now, if you find that you are having a problem with that, then you go to your doctor and you ask, can you put on an alternative medication? Because there are enough antihypertensive medications, that choices out there, that we can minimize some of those side effects. Also, the longer you stay off of your medication, the more damage happens within your body. And the more the damage happens within the body, sometimes the hypertension will rise and become even more uncontrollable. So whereas if you had treated it early and you're taking it every day, you might have had one tablet. But because you've come and you've had a stroke and you've not been taking your medication for 5 years, 4 years, doctors now have to control your blood pressure with 3, 4, 5 different medications sometimes. And you are causing damage throughout your body. As you know from this program, hypertension is the silent killer because it causes damage, whether it's micro damage in the blood vessels to macro damage, it's causing amputations and stroke.
Okay, we've got a caller on the line. We say good evening and welcome.
Good evening and welcome to you all.
Go right ahead, please.
I would like to share my experience with what you're saying, what Dr. Mosley is saying, because, Peter, my name is Nello Bino, and you know
Hello.
me, and I know you, and I know David.
Very much so.
Well.
Yes.
I had a stroke last year in United States of America, to be exact, on September the 20th, 2021. And I support Dr. Mosley in all the things he's saying about the 3-hour time period and the things that you have to do and the doctors made me do, and it helped me a lot. And I was given an injection called TPA. Maybe he will know about it, but it helped me a lot, Peter. If I always, people have said to me, if I was in Barbados, I would die. Because why?
What interests me, Nello, is how it has changed your life. Having a stroke.
Having a stroke has changed my life. I walk with a cane, but the fact is that I'm a little unstable. Okay, I walk and I need to exercise more. They advise me there to drink water, cut back on salt, look at my diet generally. And
how frustrating is that?
Sorry?
How frustrating is it?
No, it's not frustrating.
What
Good
is it?
evening.
If all
Dr.
that change has
Mosley,
taken place, what does it do to you in terms of adjustment?
adjustments, I haven't had to make very many. From the point of view that, well, I've got to watch what I eat. And that is something I have to do and watch my weight and things like that. And that is, that is, as I get younger, that's things that I have to do, David.
Thank you very much for joining us, Nalo, and it's certainly great to have you here to tell us about your experience. And you stay well, okay?
Yeah, and
Thank you.
Right.
We've got to take a break now for lotteries, and then we'll be back.
Thank you. This is of your health, your action of strokes and stroke recovery. We have a caller on the line. Good evening.
Good evening.
Good evening. I understand that you had a TIA recently?
Yes.
Okay, Dr. Mosley, what is a TIA first of all before we hear our caller's experience?
A TIA is short for a transient ischemic attack, and it's essentially a stroke that has, or the stroke symptoms that have lasted less than 24 hours.
Okay. All right. So, caller, would you like to share your experience with us? How did you know that you were having a TIA?
Okay. I was just standing in the doorway, and all of a sudden I felt this strange sensation down my. I had this strange sensation down my right arm, and I was standing with a glass in my hand, and then all of a sudden the glass dropped out of my hand. And so I said to myself, something is wrong. And I went and I looked in the mirror because I said, I think I'm having a stroke. But there was nothing wrong with my face or anything like that. And then the phone rang, and I couldn't understand, everything I was saying seemed muddled to me and was muddled to the person on the end of the phone. So I said, what is wrong? I got scared. I got scared, and, I called for help. You were talking about the face and all of that. I kept looking in the mirror to see if my face was twisted or anything like that.
Yeah.
And so I called my doctor, and I explained what was happening, and he said, go straight and get yourself a CAT scan, because it sounds as if you're having a TIA. I had never heard about it before, and it was scary. It was very scary.
What has happened since then?
Well, I had, maybe I could go back a little bit. I had taken a COVID test, a rapid antigen test, and it came back positive. And so I decided to just stay at home and do the 10-day isolation. I didn't go to get a PCR test. So when I went to get the CAT scan, they wouldn't allow me to do it because when they tested me, was still, positive. So I was sent to the QEH hospital, and I did get the CAT scan done, and since then I've been attending my doctor, and I'm also a heart patient. I've had 3 heart attacks, so I don't know if there's a connection between the rapid antigen test, having the stroke as a result. I can't tell you that. The doctor will have to tell me that.
Are you hypertensive or diabetic or both?
Yes, I'm hypertensive.
And for how many years have you been hypertensive?
Oh, I have been hypertensive. Maybe 15, 20 years.
Dr. Mosley, your thoughts?
Yes, I'm very concerned when I hear this. Remember, we were talking about the modifiable risk factors. But one of the things that the COVID virus has been shown to do is that it has been shown to make the blood, for want of a better term, clot more easily. And that has also increased the risk of patients developing strokes. Now, the other thing, of course, to note is that she was diagnosed with a transient ischemic attack, or TIA. And one-fifth of all patients who present with TIAs, or transient ischemic attacks, go on within 90 days or 3 months to develop full strokes. So she has to be incredibly careful right now to follow what her physicians say and to be compliant, to be obedient in taking the medication. If I fall into doctor speak, please let me know. Um, but she has to be very, very careful and along those lines. And I would think the risk also of the heart being involved as well. That's another
Mhm.
modifiable risk factor that we didn't get a chance to talk about. But definitely, given the history of having a heart attack, sometimes when that can cause the heart not to beat as well or as regular. And when you have irregular heartbeats, particularly that have that sort of cause, that is the second most likely modifiable risk factor that we have to control, and that increases your risk by 5 times. So there are a lot of risk factors here, and I would advise this patient here to make sure that she sees her doctor on a regular basis and follow up with her medication.
I'm
Thank you.
curious about her age.
67.
67. Now, throughout this series, we've not only been told about exercise, about diet, but exercise has also been identified as crucial. Now, when you are in her situation, how much exercise can you do?
But I'm glad that you asked that, Dave. That falls right into my specialty of rehab medicine, where I'm a physician whose sole purpose is the quality of life of the patient as opposed to curative medicine. So I look at how best to get the patient into doing things that would fit them into the community and the household. So in her case, we would have to obviously evaluate her and see how well she could tolerate any form of exercise. Given the history of the heart attacks or MIs, as well as the stroke, it doesn't mean that there isn't any exercise that she can do, but it would just have to be monitored, and we'd have to watch and see what she could tolerate and what she couldn't tolerate. But again, when we're doing these modifiable risk factors, such as what the patient has presented on the telephone, we also have to bear in mind that they work hand in hand with other things. So diet has to be included in this for sure, as well as just anything that would relieve any sort of stressful situation. Because believe me, stress does contribute. By stress, I mean psychological issues
Mhm.
um, that would cause you to worry unreasonably.
Right.
How
I do
active are you,
exercise.
caller?
I do exercise at least 3 times a week. Sometimes four. I go to the Heart and Stroke Foundation. I could also say that I've had, along with the 3 heart attacks, I've had open heart surgery. So, I try to not I try, I do follow my doctor's advice. I exercise regularly, reduce my salt intake, try to reduce my sugar intake as well because I don't want to develop diabetes. So I try to live and follow the advice of the doctors. Yeah.
Okay. Thank you very much. And you keep active and you keep following the guidelines. Thank you so much for sharing with us. We're going to
My
take a
pleasure.
quick break, and when we come back, David, we have quite a few questions via WhatsApp. So
Thank
we'll
you.
do that when we come back. This is Your Health, Your Action of Strokes and Stroke Recovery. We have a number of questions via WhatsApp. Good evening all. What happens when you do get a suspected stroke victim to the hospital within that 3-hour window, but they spend 10 to 14 hours in A&E before getting attention or seeing a doctor? How then will they get that injection that could reverse some effects of the stroke?
Peter, I will answer that by saying that there is a that specially designed fast track mechanism for strokes, because we recognize that time is brain tissue at the hospital, and it has been proven over and over again, both internationally and locally. The 10 to 14 hours in accident emergency, unfortunately, I think that is a bit of an exaggeration, because once the patient has been identified as having a stroke, they are immediately, well, not immediately, but they are quickly assessed. As an X-ray is done of the brain, what we call a CAT scan, to determine whether it is either a bleed or due to a clot. And then once it's been proven to be done, from a clot, then we start to we begin to start the intravenous medication and put the medication in the veins to get rid of that clot.
Okay.
Believe me, I can feel the frustration of the stories that have come out, but not all of them I can verify as being true. Once you get the patient there and they fit the criteria, they are dealt with quickly and swiftly. Because believe me, it makes less work for me if we get the symptoms reversed quickly.
Okay.
I want to
So
return
again,
to the case of the lady with the TIA, because at 67, obviously a lot has happened in her life over the years to contribute to where she is now. But let's talk to the young person who is 37 or 27 and how they are going to conduct their life in such a way as to avoid this situation, given all the challenges that we face as being black people to begin with.
And that is where I was going with regards to the risk factors. Because once you recognize that you're black and you're male, for example, and you have a history or somebody in your family has had diabetes or hypertension, you've got to take the precautions. The onus is on you, not the doctor, not the nurse. The onus is on you. An ounce of prevention is worth a pound of cure. I mean, one of the things that I've noticed creeping back up, and I'm going back to the risk factors again, is Dr. Tony Gale did a wonderful job in stopping the island from smoking. But I see that cigarette smoke and marijuana smoke has crept back up. You've had a family history of diabetes. Your relative has had a stroke. You're 37 years of age. You're smoking cigarettes, which increases your risk of getting a stroke by double. You're drinking alcohol, which is more, if you drink more than 2 drinks per day, increases your risk factor by a half. But if you drink more than 7 drinks per day and you think that you're invincible and nothing's going to happen, it increases your risk factor by 3 to 4 times. You're smoking marijuana, which has smoking marijuana is different than taking medicinal marijuana, which is not in a smoking form. Let me just clarify that. But that increases your risk factor just a little less than cigarette smoke by 1.5 times. But a lot of the marijuana users that we see out here that are smoking, they casually smoke both cigarettes and marijuana, which increases their risk by 3 times. So your lifestyle modification should start when you are young.
Dr. Mosley,
Yes.
cigar smoking is on the rise in Barbados.
No.
You said cigarettes, but let's address cigars.
Cigars, one cigar when I was going through medical school was addressed as being equivalent to 10 cigarettes or half a pack. That is the most inane and silly thing to do in a population where we have non-communicable diseases of hypertension and diabetes there. You're basically begging for a stroke. I can't put it any clearer than that.
We have
So,
a...
I mean, oh, go ahead.
No, it's all right. You continue.
No, I'm just saying that I understand David's question, which is basically, and I'm going to reiterate, your lifestyle modifications start now. Okay? And I salute the Heart and Stroke Foundation for starting it in the childhood, when people are even younger, and education begins then. But it must continue through your young adulthood, because it cannot start when you're at 55 and you're trying to reverse the damage that has been done already.
Okay. Good evening. Dr. Mosley used the acronym FAST and the need to get to the hospital within 3 hours. Is there anything that can be done at home should one be unable to reach in the time frame or even obtain treatment?
Unfortunately, no. Find your way to the hospital. I can't make it any plainer than that. I will add one other slight thing to that FAST acronym. Those are the most common signs and symptoms, but there are other symptoms that would concern me if I heard a patient come in, a hypertensive patient in particular, and told me that they'd lost vision in one eye. That has also been shown to be the herald or to warn people of an oncoming stroke. So any visual disturbances that have happened in a short period of time, particularly in one eye, that is also warrants a visit to the doctor as soon as possible.
Okay. There's one viewer here who wants you to know that their family member, a stroke victim, remained in the A&E for 24 hours. No beds. He was finally transferred to Bayview.
Okay, well, I'm sorry to hear. I really am. But as I said, once you get the patient there within a 3-hour window, then it's up to the doctors now to assess the patient and make sure the patient is a candidate for thrombolysis or the clot busting intravenous drug. Not everybody is a candidate. In particular, if they've had a stroke that has led to a bleed, we can't treat that because you can worsen the bleed or worsen the stroke. If the patient has other things on board, other comorbidities, like maybe even cancer and stuff, those are things that need to be assessed. But at 24 hours, I have to apologize on behalf of the hospital, and I'm glad that they got medical attention wherever they went.
What are some of the complications after you suffer a stroke?
Yes. And this is why we set up the stroke unit. There are a lot of complications because as we went through, the brain controls all of the functions of the body, whether directly or indirectly. Some of the more common ones would be you can become what we call unstable or weak on one side of the body, and that can lead to the fact that you can't walk or you may be confined to a wheelchair. The mere fact that you are unable to walk or be as mobile as possible can open you up to all sort of complications. We mentioned some earlier today, such as bed sores, but even developing clots in the leg. So that's why when patients are admitted to any hospital, we aggressively treat them with regards to, first of all, making sure that these complications are not present, and then we look to preventing them as well. So in the case of the mobility, we try to mobilize them as early as possible. Sometimes the physiotherapist will visit as early as 24 hours post-stroke, and that was definitely solidified by having a stroke unit. The other complications you can have are communication issues, or what we call aphasia, where the person is unable to understand any language or unable to get across or talk properly. And that is where we have speech and language pathologists. The old term for them was speech therapists, where we try to improve the patient's independence by improving their ability to communicate. The one that we spoke about earlier, which is the one that was responsible for the death of quite a few of our strokes before the stroke unit, is the inability to swallow properly. Again, the speech and language pathologists, as well as the nursing staff, are very important in helping with that. And then there have other myriad of complications, whether it is painful shoulders, which sometimes we have to mobilize quickly and give the appropriate medication, right down to things like personality changes and depression. One of the things that I would love for all of us to do and to recognize is that up to one-third of patients who have had strokes can also present with depression, and sometimes they need to be assessed quickly so that the appropriate medication can be administered to them.
We have to take another break, and when we come back, I think, Dr. Mosley, we're going to ask you to précis all of your concerns and advice all in a short space of time. We'll be back. In the 2 minutes that we have left, Dr. Mosley, what is top of mind for you that you would love us to take away and underscore?
One, time is brain tissue. You must get to the hospital as quickly as possible if you suspect a stroke. Two, the symptoms and signs, remember the acronym FAST. Face, arms, speech, time to get help. Three, Barbados has one of the only stroke units in this area of the world, and we try to put all the stroke patients in there so that they can get benefit of stroke rehabilitation. Four, thrombolysis is available to all Barbadians. And again, time. Time is brain tissue. Thank you.
Thank you so much, Dr. Mosley, for joining us tonight. David?
Well, this is yet another example of the challenges that are presented to us as people and as a country when it comes to grappling with the issue of NCDs. Strokes are certainly creating a lot of problems within our country, and I'm particularly intrigued by the challenges that are faced by those who have both hypertension and diabetes. And we have to do a lot more work in trying to get people to appreciate and understand the steps that need to be taken to better protect themselves from these two particular diseases.
Thank you very much for joining us this evening. Thank you very much to Dr. Mosley for taking the time, for sharing with us and scaring us, but I hope it scares you into action. And you can join us again next week at 8:30 for your health, but most importantly, your action. Good night.
Good night.